Okay, so there is 4 o'clock, so welcome everyone to another ESID Grand Round webinar. First, we have to thank Jeffrey Moore Foundation for supporting these educational events. It is really very valuable. And today, the topic of our webinar is monogenic atopic disorders. It is actually quite a new topic we have never had it before, so I prepared some introductory slide for you to introduce the topic. It concerns diseases which are well known to us in the immune areas of immunity field. We all probably remember the discovery of STAT3 mutation as a cause of hyper IgE syndrome. And it was really the breakthrough discovery. And it was not the first one in atopy, as you see on the timeline. There are other diseases listed before, but actually it was the first one who it directed directly to our immune mechanism, so we all remember that. And from that time, the new genetic possibilities led to discoveries of many other disorders characterized by this Th2 dysregulation. But later on, the first time in 2018, it started to form a group, I mean, defined group of diseases, first described by Joshua Milner, with several reviews following that first discovery. And these reviews are in agreement about the topic. They have slightly different subcategories, but mostly they agree that we can subdivide primary atopic disorders to several subcategories. They are listed on the slide. And we also wanted as ESID to contribute to this topic, and we prepared today's webinar, which we are going to start with case reports describing the field and showing also some possibilities of Th2 biologicals, which are really on the field, clinically available, and they are great. Then we have some trip to the history with the history of hyper IgE syndrome and some possibilities of treatment of that syndrome. We will have an overview of the topic, and we will finish with STAT6 gain of function and STAT6 gain of function consortium, which is the recently described a disorder in this field. So I hope you will enjoy the information, which I hope will cover the field well. You can use question and answers, or you can use chats to pose your question, which we will answer at the end of the webinar. And we can directly start with those case reports. So I do not know if Raffaele is here. Raffaele Badolato from Brescia. He has the first talk, and he will show us patients with STAT pathways disorders. Thanks. Raffaele.
Hi, Anna. Thank you. Hello, everybody. Thanks for inviting me. I will start sharing the screen. Yeah, I'll show a few cases of patients that are representative of a STAT signaling resort, and taking how a broad view of this kind of patients. And actually, I think we can summarize the manifestations of patients with STAT signal disorders under 4 clinical group of manifestations. They might present respiratory infection, they present autoimmune diseases, severe eczema, or and hyper IgE and eosinophilia. So if we start with patients with, I thought that it was important to include also patients with the STAT1 mutations, mutation gain of function. This is a patient who is actually 33 years of age. He presented candidiasis when he was 6 months of age, and then later on he has developed cryptococcosis and as a lymphadenitis. He had multiple respiratory infections leading to bronchiectasis. But what is unusual, he also presented leishmania's infection and thyroiditis. So he presented a number of intracellular pathogens infections. So it looked at it was more than a defect of STAT1 signaling. We actually looked at IL-2 and IL-5 signaling phosphorylation. You can see in these patients that there is an increased phosphorylation in these patients and the other patients with the STAT1 gain of function, which is affecting both IL-2 and IL-5. Because there is a redundancy and overlapping mechanism between STAT1 and STAT5, we have also analyzed phosphorylation of IL-2 and IL-15 through STAT5. You see that there is a decreased phosphorylation of both IL-2 and IL-15 in patients with STAT1 gain of function, and this was associated with the reduced cytotoxicity and proliferation of NK cells that you can see here. There is a reduction of in the Western blot. Interesting, this patient also has a repeated number of leishmania reactivation. So we had to find a solution for this situation. So we decided to put in on ruxolitinib, and the inhibition of STAT1 phosphorylation actually resulted in preventing leishmania infection, and also increase of platelets and lymphocytes in this patient. So we see that there is a crosstalk between STAT2 and STAT1, sorry, and STAT5. So let me come to another group of patients, the patient who present a Th2 and Th polarization associated to Th17 deficiency. We have 3 patients here presented. A patient who actually had a pneumonia and staphylococcal infections. Actually, she presented a high number of eosinophils, high levels of immunoglobulins, and also lymphadenitis. Then we have a second patient with normal, actually, lymphocyte counts. We have a second patient which was quite similar, but he had much more severe dermatitis, allergen sensitization, and lymphadenitis, and normal lymphocyte and immunoglobulins. And then we have a third patient with severe dermatitis, pneumonia, and also viral infection, who presented quite severe infections in terms of sepsis and pneumococcal infection, elevated IgE, and abnormal lymphocyte subsets. Coming to genetic features of this patient, the first patient carried a STAT3 mutation, a loss of function mutation. The second patient was a patient without actually any identified mutations, who probably was just sensitized, was a sensitization to allergens. And then the third patient actually was carrying a DOC8 mutation. So the first patient had the typical loss of function of STAT3, which resulted in reduced phosphorylation. These are the patients with the STAT3 loss of function mutations. I'm sure that we will talk again during this webinar about these patients. And then there was the patients with DOC8 mutation who had a polarizations in terms of CCR4, with increased expression of CCR4 and CD25 on activated T cells, which is typical of both DOC8 patients and patients with Omenn syndrome. And let me finish with the patients with specific abnormalities affecting the Th2 manifestations. So we mean eczema and hyper IgE and eosinophilia. In Italy, we carried out a pilot study, including patients with a severe eczema, which required systemic treatment. Most of these patients were on dupilumab or cyclosporine. And among these patients, it was 10 patients, but now the study is recruiting many more patients. We identified a 12-year-old girl who had high high immunoglobulins and increased eosinophils, and she actually carried a mutation of the gene encoding for 130, but there was a missense mutations, and apparently this resulted in reduced signaling through IL-6 receptor. So this is probably related to the group of disease which are due to mutation of the GP130 subunit of IL-4 receptor. So let me summarize. We have in the group of STAT signaling defects that are associated to candidiasis and bacterial infection. We could call them Th17 type. And then we have the other manifestations which are of the allergic type, which are Th2 type. And then we have a mixed type like Job syndrome, for example. And this is my last slide. Thank you for listening.
Thank you, Rafaela. It was fast. You saved time. It is nice. There are no questions yet, and we will answer questions anyway at the end of the webinar. So now I invite Horst von Beirut with his case report, and he will show us the dupilumab in STAT3 hyper IgE syndrome.
Yes.
Horst is from Charité from Berlin. Yeah.
Yes. Okay. First question always, if you sit in your office, can you hear me? Can you see everything? Is it in slide presentation? I think so.
Yeah.
Okay. If there's no other opinion to that, I will start. I will now zoom in at STAT3 autosomal dominant hyper IgE syndrome due to mutations that are mostly dominant negative. I will start with a boy. He was born at term, but he developed a pneumonia at the second day of life. He was intubated and ventilated for 5 days, and he was discharged after 14 days of his life. At 20th day of life, he presented with severe eczema with pustules. My speaker before, Rafaela, called this pyoderma. I will perfectly go along with this. And he had 31% eosinophilic granulocytes. So this is STAT3 mutation autosomal dominant hyper IgE syndrome. What are the clinical issues of dermatitis in dominant hyper IgE syndrome? The clinical issues are that they're beyond the clinical triad. You have the pulmonary infections caused by Staph aureus and Streptococcus pneumoniae. You have the bone brittleness, the retention of decidual and delayed detention due to the impact on the TGF-beta pathways, and you have the dermatitis, and we will focus in this case report on the dermatitis. And you have the issues of lymphoma and aortic dissection. We will discuss this later in the seminar. If you zoom in on dermatitis, 50% of the neonates present with excessive neonatal rash. So you can make this diagnosis very early in life if you're a neonatologist who says, this is beyond things that I've seen before usually. The eczema with scoriates later in life is in our hands, in our outpatient clinic, very usually beyond 50, despite excessive treatment and training. And a third issue that is, in my opinion, underrepresented in the literature is recurrent otitis externa. It's external otitis. It's not otitis media. It's basically otitis externa. We treat these eczemas with all the things we know with emollients, topical steroids, eosin, oral antihistamines, topical calcineurin inhibitors, oral cyclosporin, or oral corticosteroids, melatonin if they don't sleep. We treat the otitis externa with antibiotic prophylaxis, with HTO2 for local disinfection. We give repetitive courses of Pseudomonas. We do tympanoplastics. To make the long story short, all this does not work very well. In our patient, all this does not work very well. So we were very happy about the initial reports of dupilumab in these patients. These were reports in adult patients, and when dupilumab was then approved in Germany and in Europe for patients older than 12 years of age, we started treating 3 boys between 6 and 12. It was approved for age beyond 6. We started treating these 3 boys in our outpatient clinic, and to really make a dents. All 3 boys have never slept through the night. So they were so itchy with the skin that they could not sleep during the night. And they were bad at school, and they had all been suffering from chronic otitis externa ever since. And they all had a score at above 50 despite constant use of topical steroids and a lot of training. All had parents that were completely educated. Nothing had worked. These are the pictures before and after dupilumab. You see the pictures of before dupilumab treatment on the left side of the slide, and after dupilumab on the right side, and the success was stunning. And that was a success after 4 months. So in all 3 boys, the score went down, the reported quality of life went down, and to put the long story short, all 3 boys could sleep through the night for the first time in their life. Chronic otitis externa healed in the boys where it was chronic. All families stopped topical steroids, latest 4 weeks after start of dupilumab. The intervals of 200 to 300 milligrams were adjusted by the patients. 2 of them give it every 3 weeks. 1 of them gives it every 4 weeks. And most of them give the dupilumab in a syringe and not with a pen, because the pen is more expensive than the syringe. And most of them like it better to give it themselves. I tried both, and then I was happy that they accepted the syringe, because they don't like the feeling of the pen. But as you know, there's a pen and there's a syringe to give the dupilumab. Okay, what are the potential side effects? The most reported side effect of dupilumab is conjunctivitis. Conjunctivitis, that was something we observed, and we've now been treating basically all our patients with hyper IgE. So it's about almost a dozen patients with dupilumab, and in some of them we observe conjunctivitis. Intermittent eosinophilia, which is just a lab phenomenon and which is not a bad thing. Side effects I did not observe myself, but that are described in the literature, is the paradoxical head and neck erythema, which is a kind of shift in the kind of skin presentation. Some patients with atopic dermatitis, not with hyper IgE syndrome, are described to present with psoriasis, and alopecia and cutaneous herpes simplex infections are complications that are also mentioned. I haven't observed them. The potential severe side effect are arthritis, pancreatitis, serum sickness, and antibodies against dupilumab. Antibodies against dupilumab, I have little information on this that is published. Maybe I missed something. I would be happy to hear about this from the group. The hearsay and the hallway talk of it is that I advise the patients that the intervals are not too large. I rather advise them to give it every 2 to 3 weeks, but we can discuss it. And then in the group of patients with atopic dermatitis, it was said that Sézary syndrome may develop while on dupilumab. That's a matter of big debate in the group of allergists and dermatologists, because I think we must put it this way: in the group of patients with atopic dermatitis, we do observe more patients with Sézary syndrome, but it's not clear whether this is caused by dupilumab or whether it's just more visible because the eczema resolves. And in some of the publications, it was said that the Sézary syndrome developed 3 months after dupilumab. Usually Sézary syndrome is a low-growing T-cell lymphoma, so this is still open. What we do is we send our patients on dupilumab once a year to be seen by a dermatologist. That's all what we react, and we haven't observed this, and I'm not aware of this in hyper IgE syndrome. So that's my summary slide. We do recommend dupilumab in any patient with a score beyond 50, and that these are all patients with hyper IgE syndrome. There are further beneficial effects of dupilumab on which I did not discuss due to the to time restraints. They are the frequently reported side effects, and I think we have to follow on the issue of Sézary syndrome. And I would like to thank all my colleagues in the outpatient clinic and you for your attention. Thank you very much.
Yeah, well, thank you. It was really nice, and I am looking forward to the discussion. We still do not have questions in discussion, but so please use the opportunity, because I have myself several questions, and also I can share that the drug is very beneficial in these patients with this dermatitis especially. Okay, thank you. Thank you very much. And just now we go back to the history, and I ask Bodo Grimbacher, who lived through this beginning of hyper IgE syndrome. So Bodo, he is from the University of Freiburg. Everybody know Bodo. So Bodo, please, can you share your lecture with us?
Thank you for inviting me to present. So Anna assigned me kindly the task to report about the history of hyper IgE syndrome, which is also called Job's syndrome or Buckley syndrome. I would like to summarize that this is a multisystem disorder which does have more than an immunological phenotype. We heard already from the eczema, from birth, skin infections, lung abscesses. Those lung abscesses tend to form lung cysts, pneumatocells. And these patients also suffer from recurrent fungal infections, and we will learn later on why. And they tend to have IgE levels in the 10th of thousands. In addition to the immunological phenotype, however, patients with Job syndrome or hyper IgE recurrent infection syndrome have also connective tissue involvement. They have a characteristic face, they have retained primary teeth, so the baby teeth will not fall out, and the permanent teeth will erupt either in a double row or being blocked from eruption. Patients have recurrent bone fractures, hyperextensible joints, and scoliosis. And I'm showing you some pictures. You have seen the newborn rash already from Horst. This is how severe the eczema can become. So this is a 14-year-old girl with severe eczema. This is one of those cold abscesses. So the boy did not have fever. He did not complain because that is a particular feature of patients with Job syndrome, that they develop those called cold abscesses. They have pus, so you drain them, they have pus, but patients don't feel the infection, and I will explain to you later why that is. Patients have recurrent fungal infections, here nail candidiasis. So the Candida and the Aspergillus are the most frequently identified fungi in patients with Job syndrome. Here you can see a pneumatocyll. So here on the upper right lobe of the lung, you see here this huge pneumatocyll. It's fluid filled. So there's an abscess currently going on in this patients with Job syndrome. And here you can see that the pneumatocells, actually one of the biggest and most feared complication is that in the pneumatocells, fungus, and this is Aspergillus fungus ball here as well on the other side, and the huge pneumatocyll fungus will grow. And finally, this fungus, at some point, it's difficult to reach with antifungal treatment, so it will then disseminate and possibly go into brains of those patients. We have described the atopic facial presentation, hyperextendibility, recurrent bone fractures, and retained primary teeth when I did my postdoc period at the NIH with Steve Holland and Jennifer Puck back in the late last decade, century actually. So my task is basically to teach you about the history of Job syndrome. And it is called Job syndrome because Davis, Schaller, and Wedgwood actually coined the word Job syndrome because of the citation from the Bible that Satan went forth from the presence of the Lord and smote Job, the biblical character Job, with boils from the soul to his head because he was faithful to God. And this initially was described in two boys back in 1966. And they coined this syndrome, Job syndrome, because these two unfortunate kids had recurrent abscesses. And it took until 1972 when Rebecca Buckley, and this is why the syndrome is also sometimes called Buckley syndrome, when Rebecca Buckley described two additional boys who had recurrent infections and a hugely elevated IgE. So back in 1966, IgE has not been discovered yet. So therefore, it was the first time that the syndrome was associated with those hugely elevated IgE levels, which in the end turned out to be only not causative for the phenotype, but also just a biomarker for the disease. So it was in 1999 when I was a postdoc at NIH that we, for the first time, described the hyper-IgE syndrome as a systemic disease. So we found that the recurrent features, facial features, are present in all these patients with asymmetry and many other features. We identified the disease as an autosomal dominant trait. For the first time, we defined those double row of teeth. You can see here, those baby teeth are permanent and they wouldn't fall out with the second row of teeth erupting here. Or in this panorex of a 21-year-old girl, those baby teeth would block the permanent teeth from erupting. And we also described that IgE over the years can actually fall. So in adult patients, it's very possible that these hugely elevated IgE levels, this is a logarithmic scale, can fall into normal values, and still patients get recurrent infections and the disease progresses. So it's not a good disease marker, the level of IgE in these patients. It was 2006. So my task actually in Jennifer's lab was to identify the gene defect in hyper-IgE syndrome. And during my postdoc period, I failed. It was 2006 when for the first time, Yoshimi Negishi from Japan described that the tyrosine kinase 2, which is a Janus kinase, so you know there's JAK1, 2, and 3, and there's TYK2, that this gene is actually mutated, biallelically mutated, in children which he suggested had an hyper-IgE-like phenotype. But it took only very few months until the group of Jonan Casanova then also identified patients with mycobacterial infections without elevated IgE levels, but homozygous mutations in TYK2. So TYK2 deficiency is more a combined immunodeficiency with or without elevated IgE level, but it is not the explanation of the autosomal dominant hyper-IgE syndrome. However, the big success of Yoshimi Negishi is that he, for the first time, put the spotlight on the JAK-STAT signaling pathway in these types of patients. So you may know that IL-6 binds to the IL-6 receptor and then initiates the dimerization or the phosphorylation of JAKs and then the dimerization of STAT molecules, in this case STAT3, and the dimer then goes into the nucleus as a bona fide transcription factor. And he found out in his breakthrough paper in Nature, published in 2007, that dominant negative mutations in the DNA binding domain of STAT3 cause Job syndrome, hyper-IgE syndrome. So to my assessment, this is one of the most important papers in our whole field of primary immunodeficiency diseases, because for many, many years, we were looking for the monogenic cause of hyper-IgE syndrome. For at least 11 years, we intensively sought for it. And Yoshi was finally able to put a finger into the wound and identify the STAT3 dominant negative mutations. So why is it dominant negative? Because STAT3 needs to form dimers, and when you have two alleles, it may be that one allele is mutated because it's a heterozygous disease, but if you form dimers, then you can have 50% mutant wild-type dimers, but you will also have 25% mutant dimers, and when you will have 25% wild-type dimers. So in a heterozygous state, when you form dimers, the whole system is running out of 25% wild-type transcription factors, which is obviously not enough for some cells, but it is enough for many other cells. So I would like to remind you that these patients do not have problems in the CNS. They do not have inflammatory bowel disease. So for endothelial cells, for enterocytes, for the CNS, many CNS cells, it seems to be that 25% JAK-STAT signaling, STAT3 signaling is sufficient. However, and we were able to confirm that these heterozygous STAT3 mutations are present in all the patients we have published in our New England Journal paper. So there's a follow-up paper that all these patients from NIH actually carried these heterozygous mutations in STAT3, and they were dominant negative. However, some cells need a lot of STAT3 signaling, and those are especially the Th17 cells. So I remember Alain Fischer at a meeting when Yoshimi Negishi shared that news that STAT3 is heterozygously mutated. Alain Fischer stood up and asked the question, what about Th17 cells in patients with STAT3 mutations? Because STAT3 is the upstream transcription for Aurora gamma T, and Aurora gamma T is the transcriptional regulator for Th17 cells. So without STAT3 signaling and Aurora gamma T signaling, there might be no Th17 cells, and that is actually true. And Th17 cells protect against fungi and bacteria, especially Staphylococcus, as we learned later on. And it's actually true, and these follow-up papers by many groups, including ours, showed that patients with dominant negative STAT3 mutations are actually the human counterpart of individuals with no Th17 cells. So these patients lack Th17 cells because the lack of STAT3 or the reduced STAT3 signaling does lead to no polarization of naive T cells into the Th17 cell lineage. And now we can understand, because Th17 cells control fungi, Aspergillus and Candida, and they control bacteria, Staphylococcus, that patients with lack of Th17 cells have those clinical infectious problems. Later on, it became clear that the JAK-STAT pathway has dose effects. So if you have too little STAT3 signaling, you're suffering from hyper IgE syndrome. If you have too much of STAT3 signaling, you have STAT3 gain of function mutations and CVID-like phenotype. I want to close with other forms of hyper IgE syndrome, not to be confused with Job syndrome. This is for the foremost time, DOC8 deficiency, 2009, in parallel. So the NIH group, unlinked to our group in London at UCL, when I was working in London, identified B allelic mutations in DOC8 being responsible for an hyper IgE-like syndrome. And it's currently more appreciated that DOC8 patients have a combined immunodeficiency, as Helen Su has published in her New England Journal publication. But many of the DOC8 patients look very similar to hyper IgE patients, Job syndrome patients. And there's actually a paper in JACI which shows you how to tell those two apart. So there's a clinical score, there are clinical questions you can look at, including lab values which discriminate DOC8 deficiency from hyper IgE syndrome due to STAT3 dominant negative mutations. Then in 2014, mutations, B allelic mutations in PGM3 were identified. So they were identified in Northern African patients. And here again, at the very same time, my group and the group from Josh Milner and people from the NIH analyzed by genetic linkage analysis families with hyper IgE phenotypes and found that this glycosylation process is impaired. And therefore, this may be another autosomal recessive cause for elevated IgE levels and an immunodeficient phenotype. However, the phenotype may be as broad as severe combined immunodeficiency, and these patients may also have neurocognitive impairments. The next step was in 2018 with the identification of CARD11 loss of function mutations. Anna already alluded to that. So this is a very important paper that not only gain of function mutations, which called Benta syndrome, are present in CARD11, there are also loss of function mutations. And you may recall that there are also CARD11 complete knockout patients leading to severe combined immunodeficiency. So there's a gradient of CARD11 complete knockout, CARD11 loss of function, and CARD11 gain of function. So this is a gene downstream of TCR signaling. So you can imagine that if there's no CARD11 signaling at all, there will be also no TCR signal, and T cells will die, leading to a severe combined immunodeficiency. But if there's little CARD11, we end up with the phenotype of an hyper IgE syndrome. Then in 2018, zinc finger 341 was described again in parallel between our group and the group at NIH, led by Jean-Laurent Casanova. And we had different families where we, by genetic linkage analysis, found again the same locus containing zinc finger 341. In the beginning, there was a dispute whether zinc finger 341 was more controlling STAT3 or STAT1, and we were able to convince Jean Laurent that it is more STAT3, which is controlled by zinc finger 341. But this disease is really understudied these days. So we have still no good idea how zinc finger 341 controls STAT3 expression. And then finally, the IL-6 receptor chains in 2020, loss of the interleukin-6 receptors, and we have already heard of the IL-6 ST, but also of the alpha receptor. If they're mutated, they cause the same phenotype. That's easy to imagine because I taught you that the IL-6 receptor is upstream of JAK-STAT signaling. So if the patients do not see the IL-6, they cannot produce inflammation, right? So this is why these abscesses are cold, because they do not see the massive amount of IL-6 which is being produced because there's no downstream signaling, and the cells are agnostic of the elevated IL-6 levels patients may have. And finally, we will hear today about STAT6 gain-of-function mutations. So this is why I'm only showing you the two papers in case you want to take a picture of them. So in summary, there are autosomal dominant causes of hyper-IgE syndrome, dominant negative mutations in STAT3 being the most frequent ones. However, there's also CARD11 loss of function, which is monoallelic. Then there's this IL-6ST, GP130, which can be autosomal dominant, but also autosomal recessive. And there's STAT6 gain-of-function mutations. On the other hand, there's the autosomal recessive phenotype being caused by TYK2 mutations, STOK8 mutations, PDM3 mutations, zinc finger 341 mutations, the IL-6 receptor alpha chain, and biallelic mutations in GP130. So there are still current challenges. We heard that the atopy is being resolved by anti-IL-4 and anti-IL-13 by Horst really nicely. And I agree with his clinical observations. And we use that in adults as well, albeit at a higher dose. However, there are current challenges in managing these patients. One is whether we should rather transplant patients in childhood because some of them really do bad in adulthood. And whether there's gene therapy feasible and useful for these patients, thinking of these mutations not only being in hematopoietic cells, but also in the soft tissue. And I would like to remind you that this is a multi-system phenotype, also involving joints and bones. You may not be able to correct with transplant or gene therapy. Thank you for listening.
Thank you, Bodo. I think it was really beautiful pathway to show us history of understanding Th2 dysregulation syndrome. And thank you also for your questions, because it is really an introduction of your next speaker, and Jenny, who will tell us about these possibilities of transplant for these patients. And Andy is from UK, from Newcastle also, everybody knows Andy. So we are looking forward to. I also do not know what to do with our patients.
Thank you very much, Anna, and thank you for inviting me, and thank you, Bodo and the other speakers, for setting the scene. So I think just last year I was involved in writing a review of atopic disorders associated with inborn errors of immunity, and you can see that there are quite a lot of them. I'm not going to talk about all of these in transplant, but really just concentrate mainly on one, but I am going to briefly mention, as Bodo has already, DOC8. And I think this is one of the papers that he was describing. You can see that severe allergy, particularly of food, is a significant part of DOC8 deficiency. And it's also a particularly horrible disease. So this is from from a different paper of 136 patients, looked at the overall survival. This is without stem cell transplant. And you can see that by mid-20s, there's less than 50% of patients surviving, and the event-free survival, which included severe infection, vasculopathy, or malignancy, then really it's a very significant and horrible disease. With transplantation, we transform certainly the overall survival. There aren't any other long-term studies looking at complications post-transplant, but certainly in our own practice, to my knowledge, patients mainly do very well post-transplant. And so my message for this disease, although severe allergy is a manifestation of DOC8 deficiency, it is a combined immune deficiency and not really a hyper-IgE syndrome. It's in table 1 of the IUIS classification. And if you diagnose a patient with this, then urgent stem cell transplant should be sought. I would say not even considered, but you should be referring, and then the patient and the family can discuss with a transplant physician the options available. Interestingly, in these patients, allergy can persist post-transplant, certainly for several years. And I have 1 or 2 patients where that is a problem beyond the transplant period, but they don't get the problems with infection. I don't think they get the vasculopathy developing, and they don't get the malignancy. So I'm going to move on to STAT3 loss of function. You will probably all be aware that we published many years ago now that the role of transplant was uncertain when we described a young girl with hyper IgE syndrome who we transplanted and we thought hadn't got better. And you can see here her IgE levels pre-transplant, during the transplant, and then they rose post-transplant. This was before we knew what the genetic diagnosis was. It hadn't been described at that point. And in fact, in retrospect, I think she has done reasonably well. But as Bodo has pointed out, this is a multi-system disease and not all elements of the disease are corrected by transplant. It is a horrible disease. Christo Silifis, who's one of my research fellows, presented this in a poster at ESID, and you can see the complications that patients may experience here, including infection, atopy, and other non-immunological features. And there's a significant chance of developing bronchiectasis as you age. And so that's why transplant might be considered. We actually put together a series from the UK, our own centre in Great Ormond Street, of 8 patients between the age of 16 and 18 years, with a follow-up ranging from 15 months to 20 years in our original patient. Of those 8 patients, 7 had significant pre-existing lung disease before we transplanted them. All of those patients survived, 1 rejected and was successfully retransplanted. You can see that there was a restoration of the IL-17 access in patients post-transplant. And so Christo has been doing a big survey from patients around the world on who have a STAT3 hyper IgE syndrome. And as part of that, we've been looking at the outcome of patients who have been transplanted, particularly looking at overall survival, event-free survival, and also the impact on immune and extra immune features. So you can see it really is a truly international study with patients from Europe, from the Far East, from Australia, from India, as well as from the USA. So 39 patients have 41 transplants. 5 of these were before 2010. The median follow-up of almost 5 years, but again, quite long, including our long-term patient, with a median follow-up of 5 years for survivors. Age at transplant also ranged and included some adults, but predominantly children or adolescents. And the indication was varied, mainly recurrent infection, but 3 patients had lymphoma, which was what drove the decision to transplantation. If we look at their pre-transplant morbidity, you can see that there was significant lung disease. Many had bronchiectasis or pneumatoceles, or indeed both of those. About a third of patients didn't have parenchymal lung disease going into transplant. A number of patients also had pulmonary fungal infection, which was either confirmed or suspected. And of course, one of the problems once you've got a pneumatoceal is that you can get colonization with aspergillus, which may not cause frank infection, but certainly can cause complications around the time of transplant. So pre-transplant, 92% of patients had respiratory infections, and as I say, 2/3 had parenchymal lung disease. Most of them had skin infection. There were a number of different donors used, a number of different types of grafts, predominantly peripheral blood or marrow, and a number of different conditioning regimens, although the reduced toxicity regimens are certainly more in favor than fully myeloablative. If we look at the outcomes, they're actually extraordinarily good, particularly when we compare them to other inborn areas of immunity. So our 5-year overall survival is almost 90%, with a 5-year event-free survival of 83%. And remember, these were patients who were significantly pre-morbid, and so I think these results really are excellent. There were 4 patients who didn't survive from mainly transplant-related mortality, but also particularly infection. A number needed additional procedures, a second transplant with or without a CD34 top-up or with donor lymphocyte infusion. The GVHD was not so bad. Grade 2 is not too bad to cope with. Grade 3 and 4 was rare and is obviously much more severe. And one patient had a limited chronic cutaneous infection and another had mixed acute and chronic, but unfortunately didn't survive. Infectious complications, there were some, particularly a patient of ours who had Aspergillus colonization and then developed Aspergillus infection with cutaneous and renal aspergillosis, and also an inflammatory neuroplexopathy, which has caused significant morbidity post-transplant. So you can see, I showed you earlier that we get restoration of the Th17 and IL-17 axis. In patients who have survived, the majority of them either have a reduction in respiratory infection or they don't get further respiratory infection. There has been ongoing mold colonization in 3 patients, all of whom had previous lung parenchymal disease. The eczema, however, is cured. Mixed donor chimerism seems to be tolerated, and you can see that here with the percentage of donor chimerism. In fact, our original patient has got fairly low donor chimerism, but certainly doesn't have any infectious problems. The IgE is interesting because it doesn't always normalize. In fact, it rarely normalizes, but that doesn't seem to affect the outcome of transplant. And as Bodo suggested, it's more of a biomarker than causing disease. When we look at the extra immunological outcomes, a number of patients have had further fractures. Now, that may be because the transplant doesn't actually affect the bone biology, but of course there are also the impacts of maybe conditioning and certainly steroid toxicities. A number of patients have had progressive scoliosis. There have, however, been no new or relapsed malignancies described, although it is a small number of patients. And then probably, to my mind, one of the most important questions regarding transplantation is the vasculopathy. Certainly one of our patients subsequently he was transplanted at 13 and 10 years later developed a myocardial infarction, and you can see the angiography here, which was really quite typical of the vasculopathy that you would see in a hyper IgE syndrome. But we hadn't done any imaging pre-transplant, so it's difficult to know whether this was pre-existing or whether it occurred despite the transplantation. And I think that's probably one of the most important questions going forward. Might stem cell transplantation affect the vasculopathy? Because I think if that is the case, that would argue that many more patients should be considered for it. So in conclusion, there's a heterogeneous cohort, both in terms of location and time of transplantation, as well as, of course, the transplant strategy. However, as I say, there's a high chance of survival in these patients, despite the fact that these were a significantly premorbid cohort. Transplantation certainly stabilizes lung disease, and in some it may possibly improve it, particularly in younger patients. The impact on extra immune features does appear limited, but I think more data are required, and patients may tolerate mixed chimerism. The issue around aspergillosis is important because it can certainly cause significant problems during and after the transplant, and therefore patients need to be carefully selected and considered for transplant. And then on to the bigger question, the role of transplant for primary severe atopic disorders, of which we're going to hear more shortly. And the short answer is I don't know. Again, like the DOC8, some of these patients have had ongoing allergy post-transplant, and I guess the allergy is not simply mediated through T cells and B cells, and there may be some long-lived other immunological cells living in other tissues that are either not replaced or not completely replaced during transplant and may therefore continue to cause allergy. And so I think this is probably also an open question. So thanks to all of those that were involved in collecting these data, particularly Christo, who's put it together, and the Jobe Research Foundation that funded the project. And I'll hand over. Thank you very much.
Okay, Andy, thank you very much for your really very precious experience, because we all need this kind of previous experience for the decision. Thank you also for the question about the transplantation for potentially other severe atopic monogenic disorders. It's probably the question for discussion for the future. And now I ask Laia Alsina from University of Barcelona. She is going to give us the overview. It is a difficult task, and we have heard some of it already, but Laia, please.
Thank you, Anna. Let me share the screen. Can you see the screen? Yeah, hear me? Okay, so thanks, Anna, and everybody for the invitation. I'm Laia Alsina, I'm a pediatrician from Sant Joan de Déu in Barcelona, and I'm also a member of the EACI working group on immunodeficiencies. So the term primary atopic disorders was coined by Lyons and Miller in 2018 as a subcategory of inborn errors of immunity. They are considered heritable monogenic disorders that present with pathogenic allergic effector responses. And thus, they are manifested by severe early onset and or coexisting allergic conditions, even in the absence of common signs of inborn errors of immunity, such as infections, inflammation, autoimmunity, or lymphoproliferation. So distinguishing primary atopic disorders from common polygenic allergic diseases is really an important challenge for the clinician. And it has really life-changing implications for the affected patients. For example, the transplantation that Andy was mentioning, and because we can really apply position-based therapy to the targets and to the target genetic disorder. So from the start, from 2018, when initially 28 genes were related to primary atopic disorders, there has been a growth in this field with more than 50 genes probably related now with the last classification, the last update. So it's a really growing field. And to understand what is a pathogenic allergic response and how primary atopic disorders can rise, I will just discuss very quickly with to type 2 inflammation, which includes innate inflammation and Th2 inflammation. So innate responses, they start from a disruption of the barrier of the skin barrier that induces the production of alarmins that then activate innate lymphocyte cells, ILC2, that will induce the production of cytokines that will help, of these particular cytokines will prime dendritic cells upon allergen exposure to be prone to a Th2 response as opposed to, for example, a T regulatory response. And this Th2 response will induce IL-5 for that causes this production and migration of eosinophils, and IL-4 for B cells to produce IgE that then will activate and help the mastocyte to degranulate. So this is our normal type 2 inflammation. So any disease causing a disrupted epithelial and mucosal skin barrier, or any disorder involving T cells, T cell dysfunction, Treg dysfunction, or very specifically a cytokine signaling defect, or a mast cell deregulation, when this will be given in excess, can be a cause of a primary atopic disorder. So within the EUS classification, we can find primary atopic disorders that are scattered in 5 of the categories of the 10 categories of the EUS classification. We have those related to combined immunodeficiencies caused by a T cell repertoire restriction or an impaired TCR signaling. Then combined immunodeficiencies with syndromic features in which we can have a skin barrier dysfunction and a very specific cytokine signaling problem or a cytoskeleton dysfunction. Then we have disease of immune dysregulation in which the Treg dysfunction or the defect in peripheral tolerance can be prone to a particular Th2 response, or there the immune synapse and dysfunction. These type of diseases will give more rise to erythroderma and eczema. Then we have the autoinflammatory disorders that because of the mast cell deregulation, will manifest as urticaria, and then phencopies of inborn errors of immunity that have been updated now in 2024, for which we have two diseases related with altered cytokine signaling and causing eczema. We will review, we will give like a quick overview of each of these disorders. So we will start with skin barrier defects that can manifest with neonatal erythroderma. So we have in this disorder, there is a problem with the barrier, with the skin barrier related with the desmosome and the maintenance of the desmosome. So in Comel-Netherton syndrome, in which there is a SPINK5 loss of function dysfunction, patients have a skin barrier problem with the excessive passing of allergens, given very severe food allergies, and then also the translocation of bacteria, giving chronic skin inflammation. So these patients early on in life can have this neonatal erythroderma, and then over time, when they are over the months and years, they will have a more like related to a very atypical and severe eczema. Another disease of the related to the desmosomes is any of these genetic disorders related to these three proteins can give what we call SAM syndrome, which is SAM stands for severe dermatitis, multiple allergies, and metabolic wasting. In this disorder, which is also such as Comel-Netherton, more like an ichthyosiform disease, like a congenital ichthyosis, these patients have in the skin an IL-17 dominant immune profile, and they have good response to IL-17 blocking with secukinumab. So now moving to T-cell deficiencies that, of course, besides of possible allergy, they will have severe infections and immune dysregulation. We can start with Omen syndrome that can manifest early on, again, with neonatal erythroderma, but also with severe eczema starting in the first 2 months of life. Then also with chronic diarrhea and hepatosplenomegaly and lymphadenopathies with these activated polyclonal lymphocytes, recurrent infections, and failure to thrive. Any loss of function variants with the genes causing SCID or syndromic thymic defects can manifest with Omen syndrome. And so it is so that it is the low strength of the TCR peptide MHC interaction that really contributes to the specific Th2 priming and this phenotype. So besides these forms of combined immunodeficiencies, we have, as Bodo mentioned previously, a subgroup of combined immunodeficiencies called the CBM-opathies, in which the problem is related to the CBM complex, that's its downstream TCR signaling, but also BCR signaling. And of these, two diseases typically can manifest with atopic dermatitis. So we have this CARD11 that the complete loss of function is in the combined immunodeficiencies group, but the autosomal dominant loss of function is in the hyper IgE syndrome classification. And then we also have MAL1 deficiency. Just to show you here, this is a patient we follow with MAL1 deficiency. This is the eczema that she manifested early on in the first 6 weeks of life. And typically, as a combined immunodeficiency with susceptibility to candida infection, this eczema was very quickly super infected with candida and also with staph aureus, and this patient had severe failure to thrive. Other combined immunodeficiencies, in this case affecting pathophysiologically the cytoskeleton, we have Wiskott-Aldrich syndrome, in which besides eczema and food allergy, we have very typically this thrombocytopathy that will give rise to this eczema that when it itches, then it gives these lesions of hemorrhagic lesions here. And besides this phenotype, patients will have severe infections over time, and then this immune dysregulation with autoimmunity, vasculitis, and enterocolitis. Other defects in the cytoskeleton, such as these two disorders, for example, this patient that we follow with RPC1 autosomal recessive disease, have this eczema also with this super infection that is really common with fungal with candida. So just to mention that the red flag for cytoskeleton disorders is the combination of moderate to severe eczema with photorespiratory allergies and the combination with bleeding diathesis for the thrombocytopathy. There is this group of immune synapse formation deficiencies in which we have, of course, DOC8 that has been mentioned previously by Bodo, but other diseases in which, besides of the EBV-related susceptibility, some patients will also develop a severe dermatitis. For example, this is a young teenager that we follow with EBV susceptibility without a genetic diagnosis, with EBV-induced immune dysregulation, lymphoproliferation, severe atopic, severe eczema, and over time she has developed this prurigo nodularis that is very well responding to dupilumab. Then we have the third group in which the problem is specific to Treg dysfunction. And of course, we have IPEX as a typical related disease, but also IPEX-like syndromes in with other genes related to the pathway necessary for Tregs to function, and they will give rise to this immune phenotype of immune dysregulation. That, of course, allergy is a small part of this immune dysregulation. These patients will have early onset autoimmunity and early onset enteropathy, such as this patient with total parental nutrition because of this autoimmune enteropathy. And we have the specific group that Bodo has been discussing, which is the group related to cytokine signaling pathway dysfunction, in which there is a specific Th1, Th2, Th17 disbalance, and is what we call hyper IgE spectrum disorders. So hyper IgE spectrum disorders is a subgroup within all the primary atopic disorders in which the pathophysiology is more specifically related to cytokine signaling problem, in which there is this disbalance. So in the old days, as Bodo mentioned, there were these possible diseases. We used the score, and this is what happened initially. And with this eczema that has been also very well shown by Raffaele, with this pustular dermatitis in the first month of life. But now there is a growing number of genetic disorders that are included in the hyper IgE spectrum disorders. So we have this STAT3 loss of function and all the phenocopies in which there are mutations upstream or downstream of STAT3, which so if it's upstream, the phenotype can be stronger, and downstream it might be narrow. And so, but we have these phenocopies as well as PGM3 in which we have impairment of the STAT3 signaling. Then we have CARD11 loss of function, and then STAT3 gain of function that will be mentioned later on by Stuart, and have included these two diseases that, of course, in the new classification, since the genetic defect is a somatic mutation, they are in the 10th group of the EUS classification. There are phenocopies or somatic diseases, but they impair JAK1 STAT5 signaling, and that's why I was including them in this specific cytokine signaling pathway. And all these hyper IgE syndrome spectrum disorders, they have this elevated IgE, eosinophilia, eczema, infections, and what is really particular to these disorders, the associated syndromic features of the multisystem disease. So for PGM3 mutation, I just wanted to mention that after the initial description by in 2014 of the disease of this N-glycosylation disorder impairing GP130 downstream of IL-6, then other diseases, other patients have been described with less of a severe neurological or immunoosseous phenotype, but still with a very severe allergic phenotype. This is two siblings that we follow with this prurigo nodularis that is very well responding to dupilumab. For CARD11 autosomal dominant loss of function, these patients have an hyper IgE related phenotype with this atopic disease, but also these viral infections similar to what can be observed in DOC8 patients with flat warts, periorificial superinfections. And there is a group of patients that it is mentioned that they might display skeletal features such as STAT3 loss of function. And so this is why even if it's a TCR signaling problem and not a specific cytokine signaling problem, and they should be included in the hyper IgE spectrum and disorders. Then we have STAT3 gain of function variants. I will not extend because, of course, the talk will be explained later on. Just to mention here the syndromic features associated with this phenotype. And then these two new diseases that have been recently described, and again the atopic phenotype, but also the non-immunological phenotype that goes with this altered cytokine signaling. So we have been discussing the primary atopic disorders with a Th2-driven manifestation, but we also have to remember that mast cell deregulation should be considered also a primary atopic disorder, and they will manifest with urticaria even without a full Th2 phenotype, I mean without full eosinophilia or hyper IgA. So these are these two autoinflammatory diseases that are mainly manifested with urticaria because of mastocyte deregulation. For example, in this case, these are cold urticaria that do not respond to antihistamines, and also they will, both types of patients, they will show chronic signs of recurrent inflammation or infection. So when to suspect a primary atopic disorder, of course, the allergy, severe, early onset and or coexisting allergic conditions, but also vibratory and or cold-induced urticaria rashes that do not respond to antihistamines. Then always combining with non-allergic symptoms such as unusual infections in the lung, systemic or skin with candida or viral infections, severe watery diarrhea, periodic fever, autoimmunity, lymphoproliferation, syndromic features, and in the blood count, lymphopenia and low immunoglobulin levels. And always to question family history to make sure that there are no other signs suggestive of a genetic disorder running in the family. So in these patients, we can recommend initially an evaluation of CBC to evaluate for lymphopenia and or neutropenia or thrombocytopenia, immunoglobulin levels, and TB in cages as a very basic and maybe if possible T7T and vaccine responses, but we will have to move to genetic testing. Currently, because of the new and increasing description of new diseases, probably the gene pattern will show limitations because it will not be up to date, and because also we include some disorders such as DOC8 that might have their specificities. So whole exome sequencing might be a better approach, and news also recommended whole genome, but of course we don't have this in the clinical practice. So just I wanted to mention that within the EACI Working Group of Immunodeficiencies, we initiated in 2022 this atopic initiative just to know about the use of biologicals or JAK inhibitors in patients with atopic dermatitis or severe allergic phenotype with an underlying inborn of immunity, and to know what was their response. We presented these results at the ESID in Marseille, and we will follow this evaluation with the new board members that has been prolonged to 2026. So just to conclude, primary atopic disorders are a growing group of inborners of immunity with more than 50 genes as of 2024. So primary atopic disorders are scattered within 5 categories of the UES. So this means that besides allergy, the phenotype that will be associated with allergy will depend on the, of course, on the category in which the genetic disorder is included. Sometimes you will have more infections, sometimes you will have more immune dysregulation, sometimes more inflammation. So it will depend on the location. So primary atopic disorder, of course, is not a synonym for hyper-IgE syndrome. Hyper-IgE syndrome is a specific form of primary atopic disorder. For clinicians, past medical and family history are fundamental to suspect primary atopic disorder, and we have this basic approach which will have to be combined to genetic testing and also validation with other immunological tests, and of course using identifying a genetic disorder and a specific pathway will enable us to change to use targeted therapies and to change the course of the disease, or maybe to indicate transplantation, as Andy was mentioning. And I wanted just to thank my team in Barcelona, and thank you all for the invitation.
Thank you, Raya. It was really difficult to cover a complex field, but I am really amazed how it covers such a lot of categories. So I am wondering if it really deserves some separate category for these disorders, but it is for the further discussion. And now I invite Stuart Hervey from Canada. Actually, thank you, Stuart, for joining us. I hope the time shift is okay for you. And he will tell us about gain of function in STAT6 and the allergic disease that's standing on that. So, Stuart.
Wonderful. Thank you for inviting me here. I'm delighted to share with you really what's the new kid on the block, the new primary atopic disorder, which is caused by germline gain of function variants in STAT6. And I think I'm in an easy position here because we've had such a wonderful introduction and highlighting some of the key pathways involved in allergic inflammation. And STAT6 is really, and STAT6 gain of function disease has been a disease that's just been waiting to be discovered. It's such an obvious disease because STAT6 is a transcription factor that mediates the effect of the key Th2 cytokines, IL-4 and IL-13. And we've known from mouse models and human cell models how important STAT6 was. In addition, genome-wide association studies, 20, 30 genome-wide association studies had shown that genetic changes, common genetic changes in the STAT6 gene linked to various atopic phenotypes. And so the scene was set for us to define and find a monogenic disease. And I want to really emphasize that this discovery of this new disease was really only possible because of the collaborative nature of our global community. And so we were able to link across the globe and create an international consortium that really allowed us to understand STAT6 gain of function disorder. So I think it behoves us to continue this warm-spirited collaboration, which really improves outcomes and understanding for our patients very rapidly. And so this is what the patients with STAT6 gain of function disease look like. So they develop severe early onset treatment-resistant atopic dermatitis within the first weeks of life. Really, all the patients have this. Over time, they add other manifestations, including food allergies, so multiple anaphylactic food allergies leading to very restricted diet. Some patients just receiving elemental diet by gastrostomy tube feeding. The patients have some infections, but they're not the deep-seated invasive infections we think of with inborn errors of immunity. Really, they're recurrent respiratory infections, maybe more typical of patients with significant asthma. Or the skin infections are really compatible with disrupted skin barrier, infections with Staphylococcus aureus, Candida, and molluscum contagiosum. Another huge feature of this condition is the eosinophilic gastrointestinal disease, often very severe eosinophilic esophagitis, but also eosinophilic disease throughout the whole gastrointestinal tract. These patients have the biomarkers we expect of allergy with persistently high blood eosinophils and IgE, but there's no other obvious clues for us in the classic workup we do, looking at immune phenotyping or other blood cells. And so I think just as we'd heard previously, it's very hard to get to these diagnoses through standard clinical, cellular clinical tools. And so we really encourage people to move forward to genetic testing quickly in patients with suspicion of these conditions. But as highlighted, it's essential to be aware that if we're using a panel, the panel may be limited, and most panels, for example, do not include STAT6 this stage. In the cohort, we're describing here, 2 patients died of conditions we suspect are related to this phenotype. One of anaphylaxis and another of a cerebral hemorrhage at age 35. And so I think issues with the vasculature, in particular the CNS vasculature, seems to be a feature of the growing family of STAT defects. So here are the pedigrees of those initial 16 patients we identified. And so, for example, let's get the laser pointer going. If we look down in the right-hand corner here at family J, this is consistent with a classic autosomal dominant pattern where we have individuals affected in every generation and those individuals of different biological sex. But looking more carefully through the pedigree, you'll see that this variant appeared sporadically and was de novo in a good number of patients. And so I think that lack of family history shouldn't dissuade us from pursuing a genetic workup if the phenotype is compelling. Certainly a family history is encouraging, but in about half of these families, the genetic change that we identified was de novo. And so these patients were sporadic cases. I'll just give you a sense of the clinical severity here. So this is, as we said, essentially 100% of these patients have severe early onset atopic dermatitis. And I think this image really emphasizes the severity. There is variation in the severity, but it tends to be very difficult to manage. Although there is a hint, maybe not surprisingly, that over time, as patients move into adulthood, the skin disease becomes less severe. Here are some of the blood biomarkers, whether serum IgE levels or peripheral eosinophil counts. We use different units in different continents, but here's the gray shading of the normal range. I'm showing both these in a log scale. So we see very elevated IgE across the lifespan. Our oldest patient is now over 50, and also very elevated peripheral eosinophil counts. The gray showing 0.5 or 500, the dotted line showing that 1.5 or 1500 level that we see as meeting the definition of hypereosinophilic syndrome. I'm making this deliberately small because all those things we typically look at, whether it's flow cytometry, immunoglobulins, or other hints to look for, really show nothing. And so moving to a genetic workup relatively quickly is the most efficient for looking at most of these primary atopic disorders. And I showed you the different patients and their different genetic variants. But when we line them up against the structure of the gene, we start to see something quite compelling. So here in the 3D structure, I'm showing you the DNA. And here is the STAT6 dimer binding the DNA as it does, being a transcription factor. And what we start to see is that the genetic changes linked to STAT6 gain of function are all at the interface between the DNA and the transcription factor. And when we look at it in the linear structure, we see that the variants are particularly concentrated in the DNA binding domain, and particularly there's a remarkable hotspot here at amino acid position 419, where we're seeing recurrent genetic changes here, but we also see other changes throughout the structure. Something very interesting happens if we compare the germline variants, these germline heterozygous variants we're seeing in the STAT6 patients, with the known somatic mutations that occur in cancer that are reported in the catalog of somatic mutations in cancer, or COSMIC. When we look at COSMIC, here are the COSMIC mutation counts. We see that 419 is a clear hotspot for somatic mutations, and these are essentially all B-cell lymphomas. And that matches perfectly well with that germline hotspot we're seeing at amino acid 419. But looking through the list, we also see that a number of these germline variants that we detected are also reported in COSMIC. And so now, given this is a new condition, we feel that this is actually a quite helpful hint that a heterozygous genetic change in a patient with a phenotype that is also found in COSMIC may be a hint that this is a gain-of-function variant and may be a good reason to try and do more research-based experimental workup. I think one of the questions you might ask would be, well, if a patient carries a germline variant that's known to be a somatic variant in lymphoma, are these patients therefore at risk of lymphoma? And this is, again, a very recently described disease, but that paradigm held true for this one family. So this is a family identified by our colleagues in the UK. And the affected mother, who's the oldest in the cohort, developed B-cell lymphoma in her 50s that was treated and then had a recurrence of a more aggressive form of B-cell lymphoma approximately 10 years later. So I think this is something to be aware of with patients with STAT6 gain-of-function disease. I'll very briefly go into some of the mechanism as we're really brief here, but one very nice workhorse assay that we've been able to use is a luciferase assay that measures the STAT6 promoter activity. And we're able to compare here in the colors the activity of those patient variants against controls, whether it's a biochemically null control, a wild type, or here a population variant, and which comparing them before and after IL-4 stimulation. And we see a normal increase in these controls, but the patient variants, again, on this log scale, have very high activity at baseline that increases somewhat after stimulation. And we see this signal read out in patient primary cells, whether it's a significant Th2 skewing in the blood cells or upregulation of STAT6 targets. But because of the clinical focus of today, I'd like to move on to treatment. And we all recognize we're very fortunate to live in an area where we have a large armamentarium of medications that can target precisely multiple immune mechanisms. And so when we were thinking about STAT6 gain of function, some obvious candidates came to mind. One was looking upstream here at dupilumab to block the alpha chain of the IL-4 receptor. And then a little more downstream of that were the JAK inhibitors. And so we in the lab looked at the effects of both dupilumab and several JAK inhibitors, and were able to show that these were very effective at blocking the exaggerated patient signaling phenotype. And so as time moved forward, a number of our patients with STAT6 gain of function have been treated with dupilumab. And the results have really been quite spectacular. So here's the young man from Hong Kong whose skin I showed you initially, who after 2 years of dupilumab had significant improvement in his skin. And you can see that SCORAD dropping over time very nicely. But perhaps most powerfully for me as a pediatrician was the effect on his growth chart. And so this is the same young man who had profound failure to thrive, with his height and weight being well below the 3rd percentile. The diligent clinicians in Hong Kong had tried everything, including giving growth hormone when he was in his around 15, with really no growth acceleration. And then this young man started on dupilumab around his 19th birthday. And we see a profound acceleration in his growth and his weight, moving into and towards the normal range. And this reflected a huge improvement in his general well-being. So to conclude, I think heterozygous gain-of-function variants in STAT6 are really the newest primary atopic disorder to be discovered. And these are characterized by severe allergic disease from birth. We're starting to understand the mechanisms of that, including profound Th2 skewing. And we've been able to show benefit here. We're showing benefit from dupilumab, but in other papers from other colleagues, we've also seen significant benefit from JAK inhibitors, whether ruxolitinib or tofacitinib. And so with that, I'd just like to acknowledge the huge number of generous collaborators who are involved in us developing this story. But also to highlight that, as we saw in Bodo's history, STAT6 gain-of-function was a disease that was just ready to be discovered. And so now multiple groups across the world have identified unrelated families with exactly this phenotype and with many of these same genetic changes. So with that, I'd just like to end by saying we're really looking to expand the phenotype of patients with JAK6 gain-of-function disease. We have at least 25 of those discovered. And so I would encourage you to look for this in your patients with this phenotype. And please reach out if you have any questions or we can help work those up. And with that, I will end and say thank you.
Thank you, Stuart. It was really fascinating. It really, as you say, it is the disease who waited to be discovered to the era of all these biologicals and inhibitors that you can use. And I think they are very efficient. So thank you all. We still have some questions. I think also to all who already answered the questions. And actually, one of the questions concerned these therapies, these dupilumab and other biologicals and JAK inhibitors, and they are really very good options. But can you comment on their use in inborn errors of immunity? Do you see any additional risk? I do not know who can answer that. Maybe Stu, you can comment on that because
sure,
you have
yeah, sure. I mean, I think that's right. With all immunomodulators, we need to be thoughtful, and these are relatively new disorders for which we're using these conditions. One of my sense is that typically what we're talking about here are gain-of-function genetic changes, germline gain-of-function changes. And so when we're using, for example, the JAK inhibitors, we are turning down, but when we look at for example, the eosinophil levels, we're not turning this signaling cascade down to zero. So I think while we have seen infections in, for example, cancer patients treated with these, I think my sense is that some of our germline gain-of-function patients are perhaps at less risk of these infections. I don't want to say we should be blasé, but I think these are very effective medicines. But that's a challenging position, and Bodo's got his hand up.
Yeah, Bodo.
I have a follow-up question, Stuart. Would you still vaccinate them against zoster? Because we see in rheumatoid arthritis, we see herpes zoster outbreaks in patients on JAK inhibition. So would you do the same in your patients?
Yeah, so I can speak about sort of STAT6 and JAK1 gain-of-function. I would say that we're not saying that live vaccines are contraindicated. So vaccination against initially varicella in the pediatric age group, and then moving on to zoster would be reasonable to consider before the therapy. But I'm a pediatrician, so we don't give the zoster vaccine that often.
Raffaele, do you want something to say?
Yeah, thank you. Yeah, I agree with about the zoster vaccination, even because the the zoster vaccination is now recombinant, so it's no risk for these patients. We have used it also in patients with the STAT1 mutation, homozygous mutation, and it's not been risky, not been harmful at all. So it might be useful for preventing the side effects of JAK inhibitors. But I had a question for Stuart about the impressive effect of dupilumab on the growth. Actually, it was really striking. So I was wondering whether it was related to relief of inflammation or was a crosstalk on the STAT5, because we are aware that STAT5 mutations are affecting the growth. I mean, the STAT5B mutants have short stature. So is the short stature present, or it's that mutation that might be associated with the short stature? So which is your opinion?
It's a complicated question. We don't have the mechanism, and you're absolutely right to flag that STAT5B and growth hormone signaling are all there. I present that just because it's such a remarkable response. One of my sense was just around relief of this profound whole body inflammation, including the GI tract inflammation. The patient was able to eat well. He was able to just be relieved in terms of that profound inflammation. I think that's the sort of simple answer. Mechanistically, I'm not sure, to be frank, around that. Yeah.
Horst?
I would like to comment again on this question on dupilumab versus ruxolitinib. It's a completely personal notion, but I would always prefer dupilumab from ruxolitinib. If dupilumab works, it only affects the interleukin-4 receptor alpha chain. So you affect interleukin-4 receptor alpha chain and interleukin-13 receptor, but you do not affect all the JAK stats. And the side effects of ruxolitinib, at least in my hands, are much harder to control than dupilumab. And second point on ruxolitinib, if you look into rheumatology registers, and if you look at the data for lymphoma in the group of patients that are on treatment with ruxolitinib for lupus, there seems to be a signal that these patients who had been treated with ruxolitinib for many, many years may develop more lymphoma. So dupilumab is by far less side effects associated, I would guess, than ruxolitinib.
And Horst, may I ask you, do you think that the effect of the dupilumab is really durable? I see it for years, but I am still a little bit wondering if it raises some resistance.
That's a good question, and I'm a little bit concerned that we may observe antibodies that are developed against dupilumab. But I wouldn't be surprised, but it's a complete gut feeling that I recommend our patients to keep the level of dupilumab for that reason in a rather high and not to have large differences in the level. But Laia wants to comment on this.
Yeah, I wanted to mention about dupilumab that yes, our dermatologists, they tend to increase the lapse between doses before removal of dupilumab, and we have been relapses in this time, but then they go back to clinical response after going back to 2 to 3 weeks. So I think it's really important to gain this insight about what is safer for the patients, because of course we really want them to be better on dupilumab than probably on a JAK inhibitor, because in the long term they are less immunosuppressed. So I think we really have to gain insight about the safety of using dupilumab and the time lapse between doses to make sure that they don't get immunogenicity.
And Bodo, you still want something to add, right?
Yeah. I have my first type IgE patients now for more than 4 years on dupilumab, and it still works. I have other patients where the biweekly injections are not sufficient. So sometimes when the disease is pushing, so there's a flare in the skin disease, they need weekly injections, and that is 300 milligrams per week instead of the 300 milligrams twice weekly.
Yeah. Thank you. Okay, I see that the questions in the question and answers are mostly answered, and thank the faculty for typing the answers to some individual questions. And I believe that our webinar is at the end. I hope that it covered the field. I really have a feeling that the field is somehow formatting, and we should discuss if these diseases should form some separate category. I am happy that we overlap also with ARCIS, because just now the allergy is coming to our area as well. And if nobody has nothing to add, so thank you very much, everybody. We have a lot of attendees. Thank you and goodbye.